Hey, and did you know I'm currently accepting new patients in New York, offering both in person and telehealth visits? And I also provide telehealth for patients in Michigan, with North Carolina coming soon. And I also offer coaching, both intimacy coaching and menopause coaching, nationally and internationally. So look us up on www.femvhealth.com. I am an American board certified OBGYN, a mom, a Muslim, and I'm talking about sex. This is the Muslim Sex Podcast. Welcome to the Muslim Sex Podcast. I'm your host, Dr. Sadaf, and this episode is everything you need to know about metabolic health, weight loss, menopause, and all that great stuff. Before I get into it, remember this is not meant to be any type of medical advice. If you have any questions about your health, make sure you go speak with your healthcare provider. And as always, this is no advice on your religion. So if you have any questions about your religion, make sure you go speak with your friendly neighborhood religious leader. This is a Muslim Sex Podcast because I just happen to be a Muslim woman that talks about sex. So I'm so excited to have on with me today Dr. Jumana Al-Deek that practices in Florida. So Dr. Al-Deek, if you could please introduce yourself to the viewers and listeners out there.
Yes, thank you. First of all, thank you so much for having me. I'm Dr. Jumana Al-Deek. I'm a DO that's based out of Orlando, Florida. I have a private practice that I see men and women in, but I also have a telemedicine-based practice where I do a lot of hormone and weight loss support. So, yeah.
It's amazing. So you wear a lot of hats: family physician, menopause specialist, expert in metabolic health. What led you to focus your career on helping women thrive in midlife?
Yeah, so actually, it started off at the intersection between fitness and nutrition. So before I was a doctor, I was a certified personal fitness trainer with the National Academy of Sports Medicine. And I started a fitness company called Send Me a Trainer, and I franchised it throughout the entire United States. And I worked a lot with women in midlife. So I helped them, with weight loss. I was talking to them about menopause. This was before I got into medical school. And then as I went into medical school, of course, we didn't have a ton of training in menopause. We still don't, but we didn't have a ton of training there. Residency, a little bit more in women's health. And then, I started to see in practice, a lot of women would come up to me and be like, I can't lose weight. My hormones are crazy. A lot of them didn't even know what was going on with them. So it was me trying to connect the dots and help them, find their new stage in life. So that's kind of how it started.
Yeah. And I would say that most women, and in fact, I was sitting at a table with my sister-in-law, who is a hematologist and another physician. My sister-in-law was like, what is going on with the gynecologist? They need to be telling people about, menopause, perimenopause, and this phase of life. And she's so right. And I think now ACOG actually states that, gynecologists should start telling women by the age of 35 about midlife. And, I think that this is really late, in coming, but at least, we're finally getting there. And we're starting to focus a lot more on women in midlife.
Yeah.
So how has your perspective on women's health evolved since you first started practicing medicine?
Right. So, I definitely believe, especially because I'm family medicine, so we do a lot of prevention. And, before I didn't really do much of that prevention in sexual health and menopause. And that kind of started to change as I started to, I'm a woman physician. There's a lot of women patients that kind of gravitated towards me. And I started to see, what, I need to start talking about this because I saw the end point. I'm seeing women in their 80s and 70s and the repercussions of not talking about it. And now I'm starting to see we need to bring this up sooner. We need to talk about it in their 30s, in their late 30s, before they get to that point of no return. We need to start helping them get ahead of the ball instead of trying to fix the problem once it's already there.
So what are some of the earliest signs of perimenopause that women or even healthcare providers often miss, you think?
Yeah, so it could just and, perimenopause is so tough to see because it's not like it all happens at one time. Sometimes it could be like one symptom that happens a couple years and then the next couple years another symptom. So for example, I'll give you palpitations. Honestly, like a good 40% of my women, it starts out with palpitations. They wake up in the middle of the night at 3 a.m. They can't sleep. They're getting palpitations randomly throughout the day. Maybe it's a shoulder pain. That's another big one. Joint aches. It's honestly, a lot of it is like disrupted sleep. Maybe their periods are starting to skip around, but not always. And a lot of people, I think it has to do with their menstrual cycle only. And they don't see that it could be maybe a little bit of vaginal dryness, or maybe the libido is starting to reduce a little. It's just, perimenopause tends to affect all organ systems, not just the GYN. So
Yeah,
that, yeah, it's hard to pinpoint exactly when it starts. But I feel like now, as more people are talking about it, they're just starting to see that, you know what, maybe we need to be more, when you're aware of a problem, you start to see it more often in clinic
yeah,
and in practice.
sure. And so, how do fluctuating hormones affect sleep, energy, cognitive function long before periods stop?
Yeah. So, I mean, we know that estrogen starts to decline as we go through perimenopause and menopause. And one of the biggest issues is, estrogen, we have receptors in our brain, in our heart, in our muscle tissue, everywhere. As that estrogen starts to like change and decline, your organs are not as responsive. First of all, your mood, you can get a lot more anxiety, irritability just because of the estrogen fluctuations. A lot of women find themselves just anxious, and they never were anxious before. You start to get redistribution of the fat. It used to be in your hip and thigh area. Now it's in your abdomen. It's in the visceral fat. This causes, not just weight gain, but it can also cause diseases like diabetes, hypertension, high cholesterol, heart disease. A lot of these things end up leading to more medications being added on. Besides the fact that you're gaining weight, it's affecting their morale, how they view themselves, which ends up affecting, how they socialize and possibly their intimacy. So it's all connected.
Yeah. So, how do you think estrogen, insulin resistance, cortisol, and muscle mass all interact during midlife?
Yeah, so that's actually a great question. So, with the increased fat tissue that is being added to your abdomen, we have to know that visceral fat is actually metabolically active. It causes inflammation to happen throughout the body. With the insulin resistance, this increases the oxidative stress. It makes the endothelial lining, which is the inner lining of your blood vessels, get reduced. And so you have reduced blood flow to your sexual organs. So people aren't able to orgasm as much from this increased fat tissue, which causes the increased inflammation. It also ends up affecting your skeletal muscle, because a lot of women lose muscle as they get older if they're not actively doing resistance training and trying to gain it. That also ends up creating greater insulin resistance in the long run. Another thing is sleep is heavily affected. With the reduction in sleep, that causes increase in cortisol. This creates more stress, more inflammation, and it's just like a vicious cycle. And then sleep disruption happens because of that, the hormones adjusting. A lot of people experience hot flashes, or may not experience that, and that also disrupts their sleep. So
Yeah.
it's, yeah.
So, how do you think cortisol? We talk a lot about like estrogen, progesterone, testosterone, but what about cortisol? What exactly does that do? I have a lot of patients that come to me and say, can you check my cortisol? And if it's
Yeah.
high, how can we treat it? What would you say to that?
So your cortisol is high. I mean, you are going. It's high whenever there's increased stress. Checking it. The only time I really recommend checking it if we're trying to rule out diseases like Cushing's syndrome, where you are, this is a disease state, and we have to actively treat it differently than we would menopause. You wouldn't just check like one cortisol level in the morning to diagnose Cushing. So a lot of women feel like, oh, if you just check, I just want to know if it's high. I mean, that's great. But if it is, now what? We know you have elevated cortisol levels in menopause. Um, the question is, what are you doing to help it? And what's causing it? Is it your sleep? Is it your inactivity? Is it the stress, external stress factors going on in life? That's what I think people need to focus on changing rather than the lab value.
So, is it possible to improve metabolic health during menopause, or you think women are just fighting an uphill battle?
Well, I think it's both. So I think yes, you are definitely fighting an uphill a battle. I mean, your physiology is changing, and you can't really do a whole lot to, your husband or significant other might be doing the same thing as you, and he's not gaining any weight, but you'll do what he's doing, maybe the intermittent fasting or whatever, and you end up with like negative side effects. So a lot of women, they think, let me just do what I was doing in my 20s and 30s, and that's going to work for weight loss, but it doesn't. A lot of them will try intermittent fasting, or I'm going to go on, a crazy cardio workout. All they end up doing is losing hair because they're not getting enough nutrition and protein intake, and they end up reducing their skeletal muscle even more because they're just cardio loading it versus adding resistance training. So you have to change the way that you are exercising, the way that you're eating to match menopause, metabolic workouts and trying to get that weight off. So it's a
Mm,
change of viewpoint.
yeah, yeah. So we hear so much about the GLP-1 medications. How do you decide when a candidate is appropriate, and what misconceptions do you commonly address?
Yeah. So, I mean, they are great drugs. They've been out for a while. I know a lot of people think that they just came out, but they've been out for a while. They were used for diabetics first to help control their blood sugars. And then we just noticed that they were creating weight loss for people. And they work at receptors in the brain and the intestines, and they help, increase satiety and actually help reduce fat. So it does work for most people. I think you have to look at the greater picture when you're in menopause and perimenopause because, as I said, like a lot of these women, they're losing skeletal muscle. There was a study called SWAN, I think the SWAN study in 1994, and they looked at about 3,000 women and saw that within 2 years of menopause and then 2 years after, they lost a significant amount of skeletal muscle and increased a significant amount of fat tissue. And when you look at it, if you're sitting here taking these medications, which are great medications, they work, but they have to be done the right way. If you're taking these medications, plus you're not doing enough resistance training and you're not doing enough protein intake, you're going to lose a lot of muscle weight and not the fat weight that we want them to lose. And that just kind of puts them at risk for bone fractures, which this population is already at a high risk for because of that reduction in skeletal muscle mass and estrogen as they get older.
Yeah. So, if someone is using a GLP-1 medication, why is preserving muscle mass so important? And I think you just mentioned that, right? It prevents
Yes.
osteoporosis, it
Osteoporosis. Yeah.
prevents fractures, it prevents, basically them from becoming weaker, right? And
Yeah.
just like you mentioned, with the GLP-1s, we lose more muscle mass. And so you have to be really aware of that. You have to increase your protein intake, and you have
Mm,
more resistance exercise to build up that muscle mass.
yeah.
Um, so you emphasize muscle health, which isn't something many people associate with menopause. Why is muscle one of the most important organs for a healthy aging?
So skeletal muscle actually composes like 20% of our muscle mass. And as a result, it helps burn fat a lot more than if you were just doing cardio. So you're getting a bigger bang for your buck when you focus on that skeletal muscle. It's also the muscle that supports our bones and it helps strengthen those bones. So again, as you get older, you're going to be at a higher risk of osteoporosis and osteopenia, which can increase your risk of fracture simply because of your hormone changes. If you are doing the resistance training, you're kind of giving yourself a good groundwork so that you are not reducing as much of that bone density as you would if you didn't do anything going through this phase in life. So, yeah.
Yeah. So, what role does protein intake and resistance training play in maintaining independence and quality of life, you think, for women as we age?
Yes. Yes, that's a great question. So, when we have the skeletal muscle, that's going to give us a lot more of the, independence as we get older. I see a lot of women, unfortunately, they start to depend on walkers. They cannot get out of their seat when they sit in my office. They need, those little seats with the little side handles just to push up to get out of their seat. And that kind of can start earlier than you think. They're shuffling, they can't walk, and that just puts them at an increased risk of fracture. Again, biggest thing is fracture. When you are building up that muscle, you're working on your balance, you are moving. This is going to help protect you, become more independent, and stay independent rather than just deteriorating. Because if you do nothing, you're just going to deteriorate. I mean, the body just naturally does that. You age. And there's nothing wrong with aging, but we want to age gracefully.
So if you could prescribe one lifestyle intervention for every woman entering midlife, what would you suggest?
I would definitely recommend protein intake and strength training. You cannot go a day without doing that. It is so important. It's the cash that you're going to be using to get through life. It's going to help protect your organs, protect your metabolically, so you don't develop diseases, and protect your bones. So and your mind. You know, so there's proof that exercise helps keep people limit the anxiety and helps keep people on a more stable level. So I think it helps in multiple aspects of life.
So what does hormone optimization actually mean, and how do you think it's different than simply just prescribing hormones?
There is this concept now that's coming out, not heavily researched yet, but they are finding that hormones they're not just for symptom management anymore. Yes, we do believe in that, and that is how it started, I think. But more research, I think there was just a study that was published in the Journal of Endocrinology where they saw to be able to protect your bones, you want your estrogen level to be about 60. So, although we don't say necessarily or recommend that you must check your hormones to initiate hormone therapy, I do think there is a piece where we are looking at hormones and maybe should look at them just to give people to make sure that they're in the best ranges to protect their bones. Because after all, yes, we want to treat their symptoms, but we also want to make sure that they are protecting their bones, protecting their heart, protecting their mind. And although we don't have studies yet for all those other organs, we do now for bone health, at least. It says at 60, we want to keep the estrogen at least around that range.
Yeah, so who's an ideal candidate you think for menopausal hormonal therapy?
Yeah, so a lot of people actually are. Most, you have your simple, women in her 50s, 40s, going through menopause or perimenopause, hot flashes, minimal to no risk factors, perfect candidate. But it does not, just because you have a history of, let's pretend, factor V lighting, or even some women have had breast cancer, there are certain hormone therapies that can be used for each population. You have to, look at their full history, look at what their family history is, their cardiovascular picture. We used to eliminate people based off their age, but I don't think that it's so cut and dry anymore. Because unfortunately, after that WHI study in 2003, we ended up kind of eliminating hormone therapy as a class for a lot of women. And a lot of these women now are in their 70s, late 60s, and they're saying, well, what about me? I still have some symptoms. I have osteopenia. I'd like to protect my bones. I'd like to, get rid of my hot flashes. I might still have some of these symptoms, or maybe improve my libido, or maybe reduce my recurrent UTIs. Can I be on hormones? So these are questions I think they need to talk to their clinician about and see their risk factors and if they are candidates. But I think a lot of women probably are candidates more than they think.
Yeah, and I think that, when a lot of patients don't even realize that they're candidates, and I think that's what's tough, right? I mean, I'm
Yeah.
sure you probably come across that as well. In fact, the other person that I was talking to over the weekend, she's a
Hmm.
physician, and she's like, "Oh, should I go on hormones?" She's 55. She doesn't have any comorbidities or anything like that.
Right.
And, what she notices is that, she's starting to gain weight and she's,
Hmm.
pre-diabetic, but she doesn't have hot flashes. She's like, "Oh, well, maybe I
Right.
don't need it. Maybe it's not." And then, so then spent a lot of time educating her. But I think that, a lot of people don't realize that they are candidates for hormones, and you don't
Yes.
necessarily just have to have hot flashes to be a candidate
Right.
for, hormone therapy. And I feel like, we miss a lot of women that could
Yes.
potentially be on hormones, that it could help them in, their future and with longevity and all of this. and to
Mhm.
age gracefully, because they think that only those women that have the hot flashes and night sweats are the ones that are getting the hormones.
So, so true. I definitely agree. They even actually came out I believe that, honestly, all women should be on vaginal estrogen, whatever your background is. Like, that is I think 99% of women should be on that once they get into perimenopause, just to protect, their urinary tract system. They came out with a study that showed in April, I believe, it reduced sepsis for women, if you start them on vaginal estrogen. It's local, very minimal systemic side effects. You can't even measure the estrogen in their blood when they're on it. So I don't know. It's not talked about enough.
Yeah, no, definitely, vaginal estrogen, I have a lot of episodes on vaginal estrogen, and actually, I think that study, I don't know if you're talking about this study, but that was the one with 1.9 million women.
Yes,
They
yes,
looked
that
at
study.
That's the Epic Cosmos one. That's the one that just came out at the end of
Yep.
June, and it was published in the journal Urology. And yeah, so they talked about how women were those that had recurrent UTIs had less hospitalization, less sepsis, less death. And what they also noted, I think, which is important to state, is that it was across all age groups, that it wasn't necessarily only women that were older, but it also worked for women that were younger. And so I think that's really important. And actually, I do that with my patients that are younger, that may be in college or in their early
Yes.
20s and have recurrent UTIs. I don't feel like there's any harm in trying vaginal estrogen
Yeah.
just to see if
Yes.
that would help them.
Yeah, that's a good point that you make, actually, because postpartum, a lot of women go through kind of like a menopausal state, but they're not in menopause. So,
Right, right, absolutely, 100%. So you're right. So we have that terminology, actually, it's called the gender urinary syndrome of
yes, yes,
lactation. And
yes.
so a lot of women that are that are postpartum, right, that may be having the same symptoms that you're talking about, because we know that the hormones crash right after a delivery, right,
Mhm.
with the delivery of the placenta and delivery of the baby. And so you really do need that vaginal estrogen to help out the vulva and take care of that vulvar health. So what are one of the biggest myths you think that we have, that you spend correcting people about estrogen?
Yeah, so a lot of them think that they're gonna get breast cancer. Unfortunately, breast cancer, or that if they don't have symptoms, they don't need it. So those are the 2 things. So I spend, like, a good 20 minutes sometimes just educating them. We discuss that WHI study and how the progesterone that was used and the estrogen that was used isn't really something we commonly use anymore. We may use them, but, it was associated with just those medications. Plus, the cohort that was studied was a lot older, and we just kind of try to dispel the myths involved in that study, and make them feel a little bit more comfortable. Some of them feel like, oh, well, I have a family history, or I have dense breasts, or I'm too old, or a lot of them don't. They're worried, and understandably so. I mean, we've spent like 10, 20 years putting fear into them, like, oh my gosh, hormones. I remember in residency when they discussed hormone replacement therapy with us, it was like, well, you can prescribe it, but you got to make sure you got to tell them the risk of breast cancer, the this, and then only give it to them if they're having like really bad hot flashes, and I'm like, well, who are we? Like, what kind of paternalistic, mindset is this, that I'm the one judging if she needs the hormones or not? How am I to tell how she feels on HRT? It's or MHT now. I think the thinking has kind of changed in clinicians, and as a result, we are starting to educate our patients. But it is an uphill struggle sometimes, and sometimes it doesn't happen on the first conversation. That's why it's nice in primary care. You get to see them, once a year at least, if not more. You can always keep talking about it. Maybe they get another study, like a bone density scan, and it just gives you a little bit more ammo to be like, oh, look. Or maybe you can talk about how their cholesterol is starting to rise a little bit, and be like, this might be part of that, metabolic menopausal picture here. Maybe you want to consider hormones. And eventually, a lot of them start to see the bigger picture.
Yeah,
But yeah, it's a conversation.
definitely. So sexual health often changes in menopause. So how do you approach that conversation? Are you asking your patients? Are they coming to you? Is that usually one of the first things they bring up?
Yeah, so I'll be honest, in the beginning when I first started out, we didn't. That wasn't how we were trained. But as I started, you start to build a connection with these women. You're seeing them for years. You start to see their kids, their spouses. You realize, we are doing a disservice to women. We're not discussing this in primary care, at least. I don't know about GYM, but in primary care, it's not always like the forefront because we're busy, their diabetes, their hypertension. It's not always the main thing, but it actually does a lot. It's important for their well-being, and for the genitourinary system, their anatomy. Estrogen starts declining, tissue gets atrophied. They don't want to have sex anymore. Their relationship starts to suffer. And they're you maybe psychologically they start to feel a little bit embarrassed or shy to bring it up. So I think it's definitely important. I always, when I have my hormone conversations, I bring up libido and I say, like, how is your libido? Are you having sex? Some of them are like, no, I actually haven't had it in 10 years. And then we have a conversation. Like, why? What's going on?
Mhm. Yeah, no, absolutely. I mean, I think that, at least in my practice, most patients don't. That is not the first thing that they bring up, right? A lot of times, for me, at least in my patients, they will talk about everything else but, sexual health, and because they're embarrassed or perhaps they had a bad experience with their previous clinician where they, brought up sexual health and that clinician felt uncomfortable, so then they stopped bringing up the topic altogether. For me, libido is all about the biopsychosocial model, right? We take a look at biology, we take a look at psychologically what's happening with them, and then socially what's going on with them, and then try to address all of those things. I think that, absolutely with libido, it's a very long conversation, and it is also not a one-time conversation. It takes multiple visits to try to figure out what's going on and also in terms of treatment. So, yeah, I think that that's really important. How do hormonal changes affect desire, arousal, orgasm, and painful intercourse, you think?
Yeah. So, I mean, a lot of it is that drop. I agree with you. Multifactorial, definitely. Libido isn't just like, we fix it with one hormone, takes a lot of conversations. But that drop in estrogen ends up drying up the tissues. It makes the vaginal canal sometimes narrow, it makes it hurt. And some women aren't able to orgasm because mentally they have either checked out of the conversation with their partner, maybe because they've gained some weight, don't feel good about themselves. Hence, I feel like the weight gain and sex do come hand in hand together for a lot of these women. They feel like their body is changing. It's funny, you actually said, like, it's not one of the first things they mention. For me, the first thing most women mention is the weight gain. And, but I know as their clinician that oftentimes that weight gain causes them to not feel as good about themselves. It changes their body image, how they view themselves, and it does affect the amount of sex, their libido with their partners. So I think it is connected. I think when you are going through these changes, you are going through a lot mentally, and you may not be understanding exactly what is all entailed. Some partners are on board, some don't know either, and they may not be as supportive with their partners as they should be, maybe more understanding. Some of them are, and I'll have some people like pushing their partners to come see me just to get some help or relief. But and then also, I think a lot of people don't talk about testosterone enough. I think there's this, I guess, what's the word?
Stigma.
Thank you. Yes, there is a stigma with it. They think it's like, I'm going to get bulked up. I'm going to be like Arnold Schwarzenegger, but it actually is not FDA approved necessarily, but we don't have any FDA approved testosterone, but it is approved for use in low libido. So it's something that we have in our toolbox that we can give women. But I don't think there's enough conversations happening to be able to identify that and kind of reduce that stigma.
Yeah. Yeah, actually, so in terms of female orgasmic disorder, there was a paper actually that recently published by, it's actually coming out, I think, in the Green Journal in August, by Dr. Rachel Pope, and she talks about just kind of the process of care of diagnosing female orgasmic disorder, and also how to go ahead, or rather dysfunction, and then how to go about diagnosing it, treating it, what you can do. I think that one of the most common things that I see when I do a pelvic exam on a patient that comes in is clitoral phimosis. That's often very undiagnosed and underdiagnosed, and also not many physicians know what to do about it. I think that a lot of physicians, at least gynecologists, at least in my training, we never even bothered to look at the clitoris ever. And I only started looking at it when after I completed some courses through Ishwish. And, I think that's one of the most common things that I find. And a lot of women have never looked at their own vulva. And sometimes I have patients that come into the office and actually will be like, "Oh, I don't even wanna look at it. Do I need to hold this mirror? I've never looked, and I don't want to." But I encourage all women that are, or people that are listening to this podcast or even watching it, to, take a mirror and actually take a look at their vulva, because if something starts to go wrong, or you're starting to have pain, or, maybe you're starting the color changes, something happens to your vulva, you're able to see or know what it was like before. And now, whatever that part is that's irritating you, to be able to speak to a clinician to tell them what's going on, right? So I think that that's really important. Also, when it comes to female orgasmic disorder, we talk about not only clitoral phimosis, but we talk about pelvic floor dysfunction. We know that, the pelvic muscles contract when somebody orgasms. And so if those muscles are really tight, it's going to make it uncomfortable, and perhaps even make it very impossible for somebody to orgasm, right? And then as we go further up, we take a look at the spinal cord, at the cauda equina, and of course, then the brain. And that's where you mentioned about the body image. And of course, if you are not really into what it is, whatever it is that you're doing when you're intimate with your partner, you're not going to want it, and that you're going to be distracted, and you're definitely not going to be able to orgasm. I also think that it's really important to know that orgasm does not have to be the end goal. You don't need to orgasm, but you just need to enjoy what it is that you're doing. And as Emily Nagoski says, pleasure is the measure. So if you're experiencing pleasure, that's fantastic. You don't necessarily need to orgasm. But yeah, I mean, female orgasmic disorder is really, it's very common. And I think women don't realize how common it is that other women don't orgasm, and that there are ways and solutions. And you really need to find a practitioner that knows how to evaluate, diagnose, and treat something like that. And they say that actually, in that paper that Dr. Pope wrote, she said that the one thing that works 100% of the time for women that have primary anorgasmia is directed masturbation. And so that might be a tool that some women use for those that are unable to orgasm or have never been able to orgasm. And, definitely to go see a sex med provider. So that's really important.
Yeah, that's great. Great advice.
So when a woman says she just doesn't feel like herself anymore, how do you determine whether hormones, metabolic health, relationship dynamics, or something else is contributing?
Yeah, so an in-depth interview is important. I think just finding out exactly when this started. That's important to ask the question. Was it a couple weeks ago? Was it been going on for 6 months, years? Finding out exactly what she means she doesn't feel like herself. Is it the weight gain? Is it, the libido changes? Is it, hair loss? Skin changes? Like what's going on? Maybe increased anxiety. So trying to pinpoint exactly what she's saying, and then figure out a solution, a treatment plan together. What does she want to do? Not hormones aren't for everybody. Some women aren't open to it yet, and that's okay. But maybe you can work on psychosocial aspects, sex therapist, maybe a pelvic floor therapist that you mentioned, for the pelvic floor therapy. Certain exercise and nutrition advice can help her on the journey. And if she if she's ever open to it, hormones are definitely an option and should be discussed. But I think making sure that you guys are both on board with the treatment plan, making sure she's comfortable with it and feels that you're somebody that she can come back to if things aren't working out, to foolproof the plan, I think is important. So developing trust.
Yeah. So, how would you say how closely are metabolic health and sexual health related?
So I think that, when you are gaining this weight and it is causing a lot of inflammation in your body, it ends up affecting a lot of the vessels, the sleep, your skeletal muscles. And as a result, you end up reducing blood flow to your clitoris because the endothelial lining of your vessels are now inflamed, not working as properly. You end up not having as much skeletal muscle and mass in your body. So, you may be able to you might not be comfortable doing certain sexual positions anymore because you just can't bend that way anymore. You don't lose it, you lose it type situation. You may feel kind of down and not yourself just because, again, body image issues, that weight gain. You don't want to engage. You don't want to be social. Definitely don't want to be having any sex if you don't feel good about yourself. And then metabolically, it may not exactly cause the reduced vaginal dryness and the vaginal tissue changes, but that is part of the picture. If we're having issues there, we're not going to have that libido, not going to be able to have enjoyable sex. So I think that insulin resistance and having fat tissue is going to create a lot of that inflammation that's going to make it very difficult for your body to function as properly as it would without any of that. So being able to have sexual intercourse becomes a lot harder, not like it was in your 20s at least.
Yeah, I think that also, for people that may have uncontrolled diabetes, that starts to affect the nerves, right? And so,
Yeah.
the sensation, also, if you have high blood pressure, the hardening of the arteries, right? We have an artery that goes to the clitoris, and so if you're starting to get plaque buildup there, right, that may also impact your ability to orgasm. So definitely, things that require sensation, things that require a lot of blood flow. If you're not getting that, then that will absolutely affect your sexual health. So that's really important. And that's why vaginal estrogen is so important, right? It helps to recruit that blood. It helps to bring back that blood flow into that area, helps with arousal and lubrication, and which is so important. So beyond medications, what lifestyle habits have the greatest evidence for improving menopause symptoms and long-term health, you think?
Yeah, so I think sleep. People don't talk about sleep enough, but we've talked a little bit about the vicious sleep cortisol cycle. So making sure that you are prioritizing your sleep, maybe eliminate good sleep hygiene, eliminating light at night, computers, TVs, iPhone, partners that snore, animals in bed, things like that. So making sure that you're sleeping a good amount of sleep, regular sleep bedtime, and diagnosing sleep apnea if you have it, treating it. That's going to improve your overall sleep and help with your wellness there. We talked about strength training a little bit, but resistance training, muscle building, that's a natural way to get the menopause money, basically that basic the key to keeping your skeletal muscle and your fat off of you as you get older. Nutrition, we've talked a little bit about protein intake, making sure you have enough vitamins as you get older. A simple multivitamin that has calcium, vitamin D in it, and enough calcium and vitamin D to supplement for your bone health. Those are all things that you can naturally do to help with menopause.
Yeah, so, we talked a little bit about stress and how it's unavoidable. How do you think that patients can help break that cycle of chronic stress?
Yeah, so sometimes you can't really fix external stressors in life, but you can definitely fix how you respond to them. So, for some women, especially as you go through perimenopause, your brain the estrogen is fluctuating a lot. And so, a lot of women have a difficult time with anxiety when they didn't before, and they may respond to things a little bit more than they did before because of that. So either treating that anxiety through therapy, through CBT, cognitive behavioral therapy, figuring out ways like hypnosis, or just finding something that will help you when you are in a very stressful environment. How do I not overreact to this thing? Maybe it's something you saw on the news or whatever it is, or work or family. You have to figure out a way to make it so that you are not overreacting to that stressor, so that it doesn't impact your body.
Mhm. So, how do you think we can normalize conversations around menopause and sexual health while still respecting different cultures and religious values?
Yeah, so I'm Muslim clearly, but our culture is often very conservative and modest, and so a lot of women feel like they can't talk about this kind of thing, maybe because they were told it was, rude or improper. But I think it's important to normalize it, and that they can feel like they trust their physician, and that this is a normal conversation to have with your physician, that this physician is probably having this like 20 times a day with their patients. You're not like the oddball to bring this up, to feel welcome to bring it up. I think that that is maybe an important aspect. I also think it's important to be mindful. Some women don't really want to talk about this with male clinicians. They might feel a little bit more awkward to bring it up with a male clinician. So I encourage them to seek out female, clinicians to discuss these kinds of topics if that's what makes them comfortable. But whatever it is, they just, we need to make them understand and I guess educate them that this is an important conversation to have, because it's not only your health, but it is not only your physical health, but this is a part of your psychosocial health as well. And, as part of our religion, God kind of tells us that our body is amana. And that basically is like we have a responsibility to take care of it, and not just physically, but emotionally. And part of that is your sexual health and your, you know, physical health.
Yeah, yeah. So what advice would you give husbands who notice changes in their wives during perimenopause but don't understand what's happening?
Yeah, so I would advise patience. This is a going to be a difficult and trying time. She is going through a lot. I would also encourage them, if they see changes. Your wife may not be aware of what's going on. She may be, because when you're in the middle of a conflict, you may not see the full picture. You might not understand that maybe you are acting a little bit more irritable, or the weight gain. You may not see it sometimes until somebody points it out, or even the reduced libido. It might be just kind of normal for you. Some women are, and they, self-reflect and see these things, but a lot of times most don't. And so it's important to help them seek the help in a gentle, kind way, without putting them on the spot or making them feel bad about it, and just understand that this is a physiological change that they cannot control, and that just like any physiological change in the body, like whether it's diabetes or high blood pressure, we are just trying to help them so that they can get the help that they need, and flourish in their life, in midlife and beyond, and not feel like menopause is the end. We're just going to deteriorate from here on. So I think that understanding, patience, and being able to spot the signs maybe even sooner than your wife can, is going to help your relationship together.
So, what's one exercise you would tell women to do? Given your background of being a trainer, and let's say, they're so exhausted all the time, and they don't have, they have so much going on. There's a sandwich generation taking care of their aging parents and also their own kids, and they're just not sleeping well. But let's say that we get their hormones optimized and they feel better, but they still don't have very much time to exercise. What would be
Yeah.
like a few exercises if you were to tell them if they only had time for these few exercises, what would it be to help with, let's say, muscle mass?
Yeah, so I would focus on large muscle areas. So squats, you're focusing on your glutes. You don't even need weights. I would prefer if you'd have weights, because that's how we build muscle. But if you can just do a couple of wall squats in your room, repetition, do at least 10 to 15, build your way up. You can even do planks. I mean, you really don't need anything but the floor to do those. Just a couple of, 30 minutes every day. If you can start off somewhere and then build on it as you get more comfortable, that's the most important thing. So, target major muscles in the body: squats, lunges, planks. Those are targeting major muscle. It doesn't have to be just those, but those are just kind of simple ones that most people can do. And you can always tailor it to what you can. I mean, maybe you can't do a basic squat. So I said a wall squat. At least you're against the wall. It gives you a little bit more support. But eventually, it is good to challenge yourself to do it maybe on a medicine ball, like a half medicine ball, to try to get some of that balance training involved as well. And because as we get older, our balance kind of goes as part of that. So just in general, focusing on those and trying your best to add a little bit every day. Not too much at once, because when people try to do like this full 5-day or 7-day a week exercise regime, they just can't stick to it. So they quit. So it's important to start off slow and build your way up.
When you talk about half a medicine ball, are you talking about the BOSUs?
Yes.
Okay. And so what is one thing every woman in her late 30s or early 40s should start doing today to set herself up for a healthier future, you think?
So definitely have conversations with your clinicians during either your annual physical or just like make an office visit. Start talking about it. You may not have any signs that are noticeable to you, but I think it's worth discussing, bringing it up to their doctor and ask, like, what do I need to expect? What studies should I be doing? When should I start bone density screenings? What kind of exercises should I be doing? What kind of nutrition should I be taking? What can I look out for? What warning signs or red flags should I look out for? And that should prompt me to come back and see you as my clinician to get help. And then, so that is number one. Number two, doing small changes in your life. If you're not somebody who's already exercising, then you need to start doing it. And I'm not talking about cardiovascular training, which I think we should include anyways, but I want to emphasize resistance training. That is important. And it shouldn't just be 2-pound or 3-pound dumbbells. It's really important to be increasing the weights so that we can increase that muscle mass. So that's another one. And then nutrition. If a lot of women, they are doing these fad diets, intermittent fasting, which are fine if you're young and your body bounces back. But as we get older, we need more protein, especially if you're working out those muscles. You need protein to build protein. So that's a big one too. Just making sure you're having enough water, enough diet, enough food in your diet, and not starving yourself.
So imagine you're speaking to a woman who's listening while wondering why she's feeling exhausted, has gained weight, isn't sleeping well, and no longer recognizes herself. What's the one message you want her to hear today?
So it's not you, and you're not broken. This is a physiological change. It is normal, and a lot of women are going through this. Most women, if not all, are going through this. It's just not talked about. So there is a fix for this. We can help you. You just need to talk to your clinician and see what your options are. But you don't have to live like this forever, and just understand that once you hit your 40s or 50s, it's not over. This is just the beginning. A lot of women, they start their careers at 40s. They're starting, to create new things. And I think when they see that their bodies are kind of failing, it gets discouraging. And I think it's important to understand that you don't need to do that. You can fix this. You don't need to feel like your brain fog is going to take over and limit you. Your weight is going to limit you, or libido is going to limit you. You can fix this. It's not a death sentence. There are treatment options.
Okay, well, thank you so much for coming on, Dr. Jumana. And so for those people that are listening and watching you, how can they get in touch with you? How can they work with you?
Yeah, so I have a telemedicine practice where I do just hormones and weight loss. It's called medmethoddirect.com. They can visit that. I also have an Instagram handle at Dr. Jumana Al-Deek. And they can always pick up my book. It's called The Menopause Weight Loss Trap. Ooh, I don't know if you can see it here. Let's see if I can. There we go. And that is out on Barnes and Nobles, and it talks about ways to lose weight, just kind of describing the physiology, some of the things we discussed. It does mention GLP-1 medications and how they synergistically work with hormones and can help you lose weight even more than just doing one or the other. So, yeah.
Right, amazing. Well, we are done here, and it's been real and really intimate. Remember, this is not meant to be any type of medical advice. So if you have any questions about your health, make sure you go speak with your healthcare provider. And until next time, this is the Muslim Sex Podcast. So thank you for listening to the podcast, and make sure you leave us a review, share and like the podcast. And if you leave me a review, I'd love to shout you out on social media. So be sure that you share it with all your friends. And thanks for listening.